Good day, doctors. Welcome to the 22nd APOA, hosted by the Philippine Orthopedic Association with the theme 60 Years of Trailblazing Orthopedics Through Diversity and Synergy. I am Rafael Iñigo Yutangco, a second-year resident from the University of Santo Tomas Hospital, here to present the use of autologous platelet-rich plasma versus saline dressing in the treatment of diabetic foot ulcers, a meta-analysis. Diabetic foot infection is one of the most significant complications of diabetes mellitus. Diabetic foot ulcerations with a prevalence of 4 to 10% have increased frequency in elderly patients, which may eventually lead to amputation. Diabetic foot ulcers develop from two major pathophysiologic mechanisms: diabetic neuropathy and peripheral vascular disease. Primary treatment goals for diabetic foot ulcers include ulcer healing, infection prevention, and avoidance of amputation. Treatment may range from conservative to surgical management. The selection of treatment is guided by wound severity, and mild wounds may be treated conservatively, while deeper ones will require surgical debridement or amputation. Platelet-rich plasma has been proposed to accelerate wound healing in diabetics and chronic ulcers. Several studies in the past have described the role of platelet-derived growth factors to enhance healing in diabetic foot ulcers and other chronic wounds. This study aims to consolidate information provided by trials comparing autologous platelet-rich plasma and saline dressing in the treatment of diabetic foot ulcers. Study designs included were randomized controlled trials comparing patient outcomes of platelet-rich plasma versus saline dressing in the treatment of diabetic foot ulcers. Patients diagnosed with non-infected diabetic foot ulcers were eligible. The intervention group was treated with autologous platelet-rich plasma and the control group with saline dressing. Outcome measures include the rate of complete wound healing and the time to complete wound healing. The exclusion criteria is listed as follows. The following data was extracted from the studies, and the search was conducted through different online databases. Risk of bias was assessed independently using the Cochrane Risk of Bias tool. Selection, performance, detection, reporting, and attrition bias were assessed using the following criteria: random sequence generation, allocation concealment, blinding, incomplete outcome data, and selective reporting. Data analysis was done through Cochrane Collaboration's Revman software. Continuous variables were described as standard mean differences, and dichotomous variables were odds ratios. Confidence intervals were set at 95%, and a p-value less than 0.05 was considered statistically significant. The overall effect was derived using a random effects model, and statistical heterogeneity between studies was scrutinized using I-squared statistics, tau-squared statistics, and chi-square tests. 5 randomized controlled trials were included in the study, and a total of 194 participants were enrolled across all 5 RCTs. The country, number of participants, age, male and female distribution, and follow-up is shown. One study did not clearly state the age distribution of the patients included. The process of PRP preparation and application is summarized in this table. All studies drew blood from the participants, and the methods of preparation and application varied among the studies included. One study applied the PRP to the participants only once. The risk of bias is summarized in these tables. All studies mentioned the method of randomization, mostly utilizing electronically generated random sequence. 2 studies did not clearly state whether concealment of allocation was done, and 2 studies clearly stated blinding of both participants and investigators, while 1 study clearly stated open-label assignment of treatment groups to both participants and investigators. 2 studies did not clearly state whether blinding of participants or personnel was done, and only 1 study had high risk of attrition bias due to a high dropout rate. 4 articles reported the percentage of patients with complete wound healing. The PRP group significantly increased the rate of complete wound healing with an odds ratio of 4.86 and a p-value of less than 0.002 when compared with the control group. No heterogeneity was detected. 4 studies reported on the time to complete wound healing in the participants, and the mean difference for the time to complete wound healing was significantly lower in the PRP group compared with the control group. And this was found to be statistically significant with a p-value of less than 0.00001. Significant heterogeneity was detected among the included studies, even when subgroup analysis was done for the follow-up period. This meta-analysis suggests that PRP is superior in terms of wound healing rates and time to complete healing when compared with saline dressing. More studies may be done in the future with standardized PRP preparation and application for better comparison. These are my sources. Thank you for listening.